Please unmute. Dr. Shobha, you can start.
We can start, yeah. So very warm welcome to all those who have joined so promptly at 4 p.m. Welcome to the Foxy Sankalp webinar for family planning. And immense thanks to Dr. Lakshmi Shrikande and Dr. Rishikesh Pai, of course. I welcome all the dignitaries. Dr. Sampath also, I can see Dr. Parag, Dr. Arun Madhwa, Dr. Krishna Lingegoda from Bangalore, and all others. Can we have the CV, please, to introduce Dr. Lakshmi so that she can welcome the gathering, please?
Yes, ma'am.
Yeah, please share. From the beginning, please. From the beginning. Yeah. Next, please. Next. Previous one. Previous one. Previous to this. Yeah. Previous to this. Previous. Yeah. Yes. Next, please. Correct. So this is the outlay of the topics today that we are going to cover. And we promise to keep it very, very clinical. We have brought in some research aspects also, but that also is a very, I think, a very on-ground work done for family planning. And of course, this is me, but I am interested in going ahead. Can we go ahead, please? Yeah, can we go ahead?
Yes, ma'am.
I am the convener for this, and this was sourced to me by Dr. Lakshmi Srikhande and Dr. Rishikesh Pai. Our gratitude and our thanks and our greetings from ICOG to Dr. Rishikesh Pai, the president of Foxy 2223. And he has been very proactive and very encouraging for all ICOG activities. Thank you, Dr. Pai, for that. Next, please. Yeah, it is my pleasure to welcome on board Dr. Lakshmi Srikhande, the current chairperson of ICOG. And I think from the time that she has took over, not a single day has passed without some ICOG noise, some activity, some celebration, and some valuable messages for not just the ICOG members, but also for all Foxians. She is the founder, patron, and president of ISOPARB of Vidarbha chapter as well. She is also the chairperson for the Education Committee of IMS, Indian Menopause Society. And to note that she is president of Association of Medical Women Nagpur, AMWN, very prestigious organization for 21 to 24. So I welcome you, Dr. Lakshmi, to open the session.
Thank you, Dr. Shobha. Thank you so much for your kind words. Yeah, please welcome Dr. Madhuri Patel, who is our First Lady Secretary General of Foxy. Yeah. And yeah, we welcome you, Dr. Madhuri. And thank you so much, Dr. Shobha, for your warm words and kind words. Please stop screen sharing.
Stop the screen share, please.
So happy, Dr. Shobha, that as a convener of this Foxy ICOG Sankalp webinar series, you are doing a great job. And I'm so happy that today you have come out with a focused webinar on hormonal contraception. As everyone is aware that India is the first country to start National Family Planning Program way back in 1952. Since then, there is a change in their policy and as well as the implementation strategies, and Government of India has added many newer contraceptives to its basket. And that is where, Dr. Shobha, our role comes, because many of our members, they are still ignorant about those newer methods, or as you have added the hormones in medical disorders, in adolescents, in endometriosis. So here is the role of Foxy ICOG to sensitize our members, our fellows, our students about the safety and about the utility of these hormonal contraception. So I'm so happy that we are contributing towards unmet need of contraception. And you know that in India, it's a huge unmet need of contraception. So very well done, Dr. Shobha. All the very best for today's webinar. And without taking much time, I hand over back to you for further proceedings.
Thank you. That was a very, very encouraging opening statement. And we do not expect anything less from you. I think from the time the tenure has started, there have been only positive vibes, not only for the immediate office bearers around you, but for all of us, the governing council members also. Thank you so much for encouraging us, Dr. Lakshmi. So it is now my duty to introduce the rest of the Foxy office bearers. Can I have the slide deck, please?
Yes, ma'am.
Yeah. So it is my privilege to introduce Dr. Madhuri Patel, the Secretary General of Foxy, who has worked shoulder to shoulder and hand in hand with the presidents, subsequent presidents, Dr. Shanta Kumari, and now with Dr. Rishikesh Pai. Day and night it has gone on, and I think we have all witnessed what a hardworking person she is and how diligent, sincere, and forthcoming. And as chairperson till last year, I can vouch that she has been very encouraging for the next generation of Foxians. Thank you, Madhuri, for all the work you have done and for your encouragement for ICOG. Next, please. Yeah, it is my duty to welcome Dr. Parag Biniwale, a postgraduate teacher and unit head at Kamla Nehru Hospital, Pune. But most importantly, he is the vice chairperson of ICOG 21-23, and he will be the incoming chair in next few years. He is also the president, Menopause Society, Pune, and he has just now completed a very successful tenure as president of Pune OB-GYN Society. And welcome, Dr. Parag. Next, please. Yeah, and also Dr. Parul Kotrawala, a friend for many years. I can say that safely with both Parag and Parul that I have known both of them as dear friends for very long term now. And Dr. Parul is a very well-known endoscopic surgeon. Sorry, that was not okay. Yeah, very well-known endoscopic surgeon and consultant gynecologist at Ahmedabad. And he is also the vice chairman of ICOG 2020. I think he is the chair elect now. He's the chairperson elect now. Welcome, Dr. Parul. And as in the course of the webinar, we will look forward to your expert comments, both you and Dr. Parag. Next, please. Yeah, correct. So it's now my privilege to introduce the chairpersons for the session so that the scientific session can begin. And I leave it to the experts whether they wish to kind of give any comment before the session starts. But let me first introduce the chairs. It is my privilege and pride to welcome Dr. Krishna sir from Bengaluru. He is a fellow of the ICOG also, and he is professor PES Institute of Medical Sciences and Research at Kuppam. He has an experience of 40 years plus. We know him as a very, very effective, very sincere, and a very as a teacher par excellence. Thank you, Krishna sir, for being here. In his achievements feature the BC Roy Award and the Distinguished Alumni Award from JNMC Belgaum. He has a number of publications to his credit, but most importantly, he has guided many young BSOGians to achieve excellence. Welcome, Krishna sir, to the session. Next, please. And of course, I take a particular pleasure in inviting Dr. Sampat Kumari, the sitting vice president of Foxy from the South Zone. I take a lot of pride in my friendship with Sampat because she is one of the most hardworking person I have known in Foxy. She did an excellent job as adolescent committee chairperson, and she therefore has been awarded so many prizes that the list is very long. And I think we will allow the audience to read that. At present, she is Deputy Director and Professor Roji, Institute of Ops and Gynae, MMC, Chennai. And I welcome Dr. Sampat. With this, I hand over the session to the chairpersons.
Thank you, Dr. Shubha, for those nice words put me. It is a proud privilege for me to chair this session where many experts in the field of hormonal contraception are participating. And as it was mentioned by the chairperson, you have been doing a great job in this field of family planning. And I think a lot many newer things which we never knew has been brought to the notice of to the knowledge of every one of us. So I thank you for this opportunity, and I welcome all the speakers for this session, and I request them to enlighten us on the newer hormonal contraception. Thank you.
Sampath, shall I start or would you like to introduce? Maybe I can start because my slide was already there. And then you can introduce the next speaker. Can you unmute Dr. Sampath?
Yes, ma'am, I've done.
Hello, Dr. Sampath? Yeah.
Yes, Shubha. First, I was not able to unmute. Now I have to introduce Dr. Ramani. No?
Yeah, so let me start my presentation because I have to speak first because time should not get wasted. Shall I start?
Yes, Shubha.
Yeah. And before I start, shall we ask Dr. Parag whether because he said a patient is waiting in labor, or shall I start my presentation?
Whichever is
Parag?
convenient.
Dhaval, let's start with the session.
Okay.
After your lecture, maybe I'll have some
Okay.
comments.
Okay, I'm trying to share now. Okay. Yes. So is my screen visible? Is my screen visible?
Yes, ma'am.
Okay, can I start then? Okay.
Yes.
Okay, so I have to speak for the next 10 to 15 minutes very, very briefly on the safety net of combined oral contraceptives. Now, this is a subject very close to the mind of a practicing gynecologist because every day from your pen onto the prescription pad, the prescription for COC has to come because it has got a world of good that it can do to our women. My heartfelt gratitude again to Dr. Pai and to Dr. Lakshmi Srikhande for the Sankalp Family Planning webinar, and thanks to the chairpersons, Dr. Krishna and Dr. Sampath. I shall proceed now. Now, this was the gentleman who is one of the pioneers for the development of the COC. And it is interesting to know that he performed IVF in rabbits in 1934, but that did not succeed. What did succeed was the pill. And the first pill, which was called Enovid, was given FDA approval in 1960. He actually paved the way for sexual revolution, changing the way women and relationships were viewed. So therefore, he is the co-inventor of the combined OC pill. Dr. Gregory Goodwill Pincus, let us not forget him, because he has given one of the most revolutionary therapeutic interventions in the world of hormones for women. So we must start with the statement that contraception is need of the hour. We must acknowledge that world population will exceed 9 billion by 2050, whatever we do. And India, as of now, occupies 2.4% of the land area, though we comprise only, we comprise only 2.4%. We are housing 17 to 20% of the world's population. And we must acknowledge that 21%, that is 1/5 of all live births, are actually unplanned pregnancies and could have been prevented. If unmet need is met, then we can avoid. The one in red is the Indian figure. The one to the left of it in black is the world figure, the global figure. So 55 million unwanted pregnancies can be prevented. And, at any given point of time, and in a year, and 22 million fewer abortions will happen. 15 million unsafe abortions can be prevented, and 90,000 fewer maternal deaths. This is what we have come to understand about the situation. So therefore, we must be aware that there is a WHO medical eligibility criteria, which makes contraception prescription actually safe and simple. Category when it is assigned, no restrictions. Category 2, advantages overweigh the risks. Category 3, risks will outweigh the advantages, and category 4 is too risky. So if you kind of make it a little more scientific in language, category 1 is a condition for which there is no restriction. So the WHO MEC, wheel of 2015 says that this MEC criteria holds good for low dose COCs, which contain less than 35 microgram of ethnyl estradiol combined with a progestogen. So that is the criteria required to fit into this MEC categories. The category 2 is a condition where advantages will generally outweigh the theoretical or the proven risk. Category 3 is theoretical or proven risk will outweigh the advantage, and category 4 is a condition which represents an unacceptable risk factor. So for limited clinical judgment, 1 and 2 means yes, use the method. 3 and 4 means no, do not use the method. So this is what we can tell our healthcare providers. But when it comes to clinical nuancing, finer prescription writing, I think the left side will remain true, and we need to have better understanding of category 2 and category 3. So to have that better understanding, we can use the MEC wheel, which offers 2000 and more recommendations for 25 existing methods, also takes into categorization. It factorizes the pre-existing medical condition, even the personal characteristics, etc. And it is developed and based on systematic review, and guideline development is very much adhered to. So the MEC wheel, to understand, if you see the selected methods in red, those are the methods. Medical or health conditions are in green. That is the outer part of the wheel. The MEC category is in the center, 1, 2, 3, 4, and on the back side are the common. So please get used to this. All parts of the wheel, You can even see the back pages where valuable information is there. And this is the base of the wheel. And you can see the categories mentioned here, which will come into play when you rotate the wheel, and the life situations on the outer part of the wheel. And then we have these methods which are currently featuring on the wheel. And you can see that the first break is that of the combined oral contraceptive preparations, the combined hormonal preparations, which includes the pill, patch, ring, and injectable, etc. And we have today with us the pill and sometimes the ring, but not the patch and the injectable. So this is the back page, which has these alphabetical numbers which help us to have finer nuancing of. So for example, if it is categorized as D in a postpartum COC situation, there is an asterisk which says D. And if you read D on the back page, it says if less than 3 weeks of delivery and she is not breastfeeding and no other VTE risk factor, then COC stands a category 3. And it is preferable not to prescribe it. So that is how the clinical judgment can be done. It is worthwhile remembering that there is ACDS criteria for, these are also MEC criteria for the permanent method, sterilization and vasectomy. This is of interest because now there is an app which can be downloaded onto your mobile, and it is from WHO. And this app has the wheel. And we can see here that when you open the app, then all risk factors open up, and we can find out whether a particular method is recommended or it is not recommended. The category 1, 2, and 3 will get displayed on the side when we select our life situation and the method, etc. And then we have the different methods also displayed, and the drug interactions also which come into play, and the emergency contraception, etc. Everything will be available on the app. This is another handy tool which is available in the WHO website. And this is very easy because it shows dark green, light green, orange, and red as category 1, 2, 3, and 4. And it is easy to see that many of medical disorders, the COC goes for red, so cannot be prescribed. But when you look at this, when you look at the next page, you can see a lot of green for COCs. So there are many situations where COCs are very, very safe. I must end this MEC story with saying that MEC are regulatory and not restrictive, and any particular case the greens are far more in number than the reds. So that with that positive message, I come to this comparing effectiveness chart, and you can see here that the pills feature in the very second most effective methods after the LARC and the permanent methods. And on the right side of this chart are identified statements which the patient as well as the provider have to read, and which gives the best effectiveness for that particular method for that patient. Before going forward, let us just see if there is an unplanned pregnancy in this 25-year-old lady who delivered 11 months back, not on any contraception. Very common story in our OPD. Amenorrhea 2 months, has had only 2 periods since delivery, and she needs a contraceptive advice. And we need to quickly rule out pregnancy before we say that, okay, we can prescribe her the pill because she is more than 6 months postpartum, which becomes an indication. So then we need to ask these questions. The last monthly bleeding within 7 days, abstained from intercourse, reliable method. In this case, it is not there. So if she has had a baby in 4 weeks, it is not there. Did you have baby less than 6 months? In this case, not there. Miscarriage in 7 days, not there. So if the client answers no to all the questions, then pregnancy cannot be ruled out with this checklist. But if she answers yes to any one of this, then you can be reasonably sure that she is not pregnant and go ahead with the prescription. At this point of time, let me add that a highly sensitive urine pregnancy test, which we use every day in our practice, of 50 MIU per ml, that is actually, within 21 days of conception, it may be negative. So therefore, if the client answers, no to all this, you cannot rule it out with a urine pregnancy test. You may have to wait on a negative pregnancy test for some more time. So we come to the oral pill with an overview that worldwide about 100 million women are currently using it. It was introduced in the early 1960s, and the first human trial in 1956 was highly suggestive. And it actually, the oral pill was discovered serendipitously, was being used for something else, and then they found that it also kind of provides very highly effective birth control. So estrogen component has remained very, very steady as ethinyl estradiol. We do not use mestranol. And then the risk will come down if the dosage is reduced. So the risk of thrombosis increases with higher dose, and the efficacy diminishes with very reduced estrogen dose. So it cannot be reduced less than 15. So if you have 15 to 30 microgram per day, use for at least 24 days if with the lower estrogen, then probably there is a highly effective contraception. So you can see the evolution of the estrogen dose reduction, and today we stand at 30 and 20, and therefore we call it low dose oral contraceptive pills. The progestin component has also seen evolution with levonorgestrel, the first and second generation containing levonorgestrel and norethisterone, and the third generation gestodine desogestrel, which are more specific for progesterone receptors, and the fourth generation is the drospirenone, which is actually a spironolactone analog and not a pure progesterone, and then cyproterone, which does not feature in COC. The 4 generations, when we talk about them, it is important to understand their effects. It is important to know that some of them may have other effects than the pure anti-estrogenic activity. They may have androgenic activity like the earlier progesterones. They may have anti-androgenic as the later progesterones, which is useful for our women in many cases. And they may also have anti-mineralocorticoid activity, which is also an add-on. So if you look at progesterones, which have all favorable activities, this one, and this one, that gives you the better progesterone. Okay, then this is a chart which is CDC recommended. And this is a chart which applies to women who are presumed to be healthy. Please read this. It is presumed to be healthy. That means they do not have any major medical problems. In them, when we say what are the essential tests which we must do before prescribing a pill, you can see class A means essential, class B means contribute substantially to safe and effective use, and class C does not contribute substantially to safe and effective use. So we must focus on what is A and what is B, which we must do before ruling out before prescribing the COC. So let us focus on the combined hormonal contraceptive, because we cannot discuss all methods, and see what is really required. So the only A is blood pressure. And there is a dash for BMI, but we can give an advocacy that yes, do a BMI, because it's better that the woman is aware about her BMI, though obesity does not decrease the efficacy of COCs. So CHC for combined hormonal contraceptive or a COC pill, BP measurement only is category A, which should be done. Nothing else is mandatory. A breast examination or a PAP or any of these tests, C does not contribute substantially to safe and effective use of the contraceptive method. So in case we are able to do more examination and testing, it is good for the woman's general screening, but it is not mandatory for contraception prescription. So this slide gives us the message that COCs can be given in women of all ages, from adolescents to perimenopause. In fact, if we have more thoughts about or concerns about the perimenopausal age group, then let me highlight here that 80% of women between the ages of 40 and 44 can actually conceive. We must give them contraceptives. HRT does not provide contraception, and the benefits of COCs is that it has been seen to reduce fragility fractures, and it also gives menstrual benefit in women who have heavy menstrual bleeding, and also it reduces the need for surgical intervention for benign diseases. So therefore, there are non-contraceptive benefits of COCs. I will not go into the detail of each, but we know that it helps in HMB, it helps in premenstrual syndrome, it helps in PCOS where there is hyperandrogenization. It also helps in endometriosis, adenomyosis, and it helps in improving bone mineral density, and definitely prevents ovarian and endometrial cancer in 50% of cases when used for 5 years and beyond. So I think we shall go ahead. Who can and cannot use combined OCs? It is suitable for nearly all women. I'll not read this out. It, 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 it also avoids unnecessary procedures, as we saw the ABC chart of which test needs to be done. The risk-benefit perspective of COC usage as far as venous thromboembolism, whether there is annually increased risk of death in those who are using it, whether there is risk of cancer in those who are using it. So VTE is one of the most notorious side effects or adverse effect, but let us see, does it really kind of matter in the big picture? The risk of VTE in normal pregnancy is 30 in 10,000. With the use of OC, it is maximum, it is 9 in 10,000. And it is only with the older formulations of higher estrogen and the more androgenic progesterones. The pill lowers the risk of VTE compared with the usual risk during a normal pregnancy. So therefore, preventing pregnancy, if it is a real priority, then prevention of thromboembolism also automatically happens if we use the COC, because it is preventing pregnancy effectively. The annual risk of death for a non-smoking young woman taking the pill is 1 in say 16,67,000, but a woman is more likely to die of other events like accidents or a lightning. Even if a woman is a smoker older than 35 years, her risk of death from the pill is 1 in 5,200, and she is more likely to die of smoking related problems. Risk of cancer, oral contraceptive linked to cervical, breast and liver cancer is a big question mark on that. We know that in Paris women, the association was stronger when OCs were used before first full-term pregnancy. And this is the research data. But let me tell you here that whenever cervical dysplasia was found to be associated with oral contraceptive use, the sub-meta-analysis of such studies has shown that it has more to do with the sexual behavior pattern of these women rather than due to COC use. But the risk-benefit perspective of COC usage will become very clear when we know that it becomes a non-invasive option for managing the vast spectrum of menstrual problems, and the rates of hysterectomy has come down because more medical management has been done, and it directly protects against ovarian and uterine cancers. So overall, I think COCs help in making gynecology more medical, and if we go about it the right way, I think we are not going to face the adverse effects which we just now discussed. So the low dose COCs are of huge benefit, and whenever a woman misses tablets, we need to tell her that if she is less than 12 hours late, then the protection is not reduced and she can immediately take. But more than 12 hours late, it is important that she consults the doctor. Probably it requires taking again and then taking protection for next 7 days, depending on the type of tablet. These are few charts which show smoking, obesity, and the use of combined oral contraceptives. And we see that younger women with a lesser BMI can take COCs very effectively, but women who are heavy smokers, probably it is not okay. Then when it comes to DVT, if there is a history in the past, please do not prescribe. Currently, please do not prescribe. Family history, we can go ahead with category 2. If there is a major immobilization, do not prescribe. If there is a surgery which is major but early ambulation, then she need not stop the pill for more than 1 week. Minor surgery, there is no need to stop the COC. The thrombotic risk of other situations, let us just look at the thrombogenic mutations, etc. In them, it is category 4. So also if there is a history of Apler syndrome, which I have not put here. Okay, then there is diabetes. If there is, non-vascular or even insulin dependent diabetes, no problem. It is just category 2. But if there is vasculopathy, etc., please do not initiate or please do not continue. I is for initiation and C is for continuation. Then if there is hypertension, so hypertension is one disease where estrogens should not be prescribed. I think progesterone only pills will be of is category 3 and category 4. And whenever there is history of gestational hypertension or preeclampsia, but currently normotensive, it can be prescribed with category 2. In women with migraine, let us look with aura, because that is where we are more concerned about stroke. And in epilepsy also, when they are on anti-epileptic drug, we take a lot of, finer detail to prescribe COCs. So these are situations, neurological situations, where we need to be careful. But without aura, no problem. Heart disease, uncomplicated heart disease, well-compensated heart disease, there is no problem. But ischemic heart disease and pulmonary hypertension is category 4. So I think the health benefits of COCs are numerous, then outweigh the risks. And, there are potential therapeutic uses, and ultra low dose are very effective, acceptable, actually well tolerated. Third generation progestogens are actually better for continuation of the pill. I end the talk by saying that, we must look at births less than 24 months interval. First birth should not be too early after marriage, and unintended pregnancy issues. So these should be the reproductive planning that we should advocate, and we should advocate intelligent family planning to our women to achieve these goals. Okay, so these should be the reproductive goals. I shall move on to say that again, that criteria are regulatory and not
मेल पे
restrictive,
देखूं किस पे
and
देखूं
family planning alone could bring more benefits to more people at less cost than any other single technology now available to the human race. Thank you very much for your kind attention. Thank you.
Thank you, Dr. Shobha. I think Dr. Krishna is not able to unmute. Fantastic.
Krishna sir, unmute yourself.
So sometimes it comes as host is not allowing.
Hello, can you hear me?
Yes, sir.
Dr. Shobha Gudi madam has made her talk so interesting and so informative. In fact, I felt as if I was sitting in a classroom wherein I was revising the entire topic of COC, and it is crystal clear as to when to prescribe and when not to prescribe, And combined oral contraceptives, as she mentioned, is one of the commonest group of contraception that is being used. So I must really compliment her and thank her for this wonderful presentation. Thank you, madam.
Dr. Parag, we should provide tea and coffee for everyone.
Thank you, sir.
Then, Shobha, next start is Dr. Ramani, no?
Yes, Sampath.
Yes. Can I
Welcome, Dr. Ramani. Dr. Parag, your comments.
Yeah, okay. Shobha, whenever we listen to you talking on contraception, it is like listening to music. No, you are so much into it. And I always believe that when you refer to the MEC, your problems are solved. And now there's a nice app which is available, and it's on your fingertips. You have all the information. So whenever there are women coming to us seeking contraception, especially in COCs, and whenever we are in doubt, we should just refer to it very quickly and give whatever best is possible for that woman. Because as you very rightly said, contraception is something which we have to, as healthcare providers for women, should promote ourselves rather than the woman asking for it. We should, may educate any woman who comes to us related to this, because apart from contraception, there are so many other benefits, especially of the COCs, which can have a positive impact on the woman's life. Thank you.
Can I have Dr. Ramani?
Yeah, please introduce Dr. Ramani.
But still for
Please show the.
Ramani madam.
Thank you, Parag, for your generous comments. I think I should not have mentioned that you have been my friend for a long time. But thank you so much.
Yes, Dr. Ramani madam was the past vice president, and she was the committee chairperson of.
Can you please share the CV of Dr. Ramani, please, Neelima, please?
Yes, ma'am.
Yeah, please share the CV. Yeah, please show the CV deck quickly. Thank you.
Yes, already we are introduced. Can you have the Ramani madam CV? Dr. Sampath Kumari already introduced. I want Dr. Ramani
Yeah,
madam.
Sampath. It's okay, Sampath. Okay.
Yes,
No,
ma'am.
one
I
minute,
have-
1 minute. Please
Ma'am.
introduce. At least few lines.
Ramakrishna Medical Center and winner of CS Dawn Prize 2006, 7 and 13. And Madam has Women of the Year Award by Bharatidasan University and Women Achiever Award from the Dr. ABJ Abdul Kalam Award 2016 and a recipient of many awards and oration. If you are continuously going to tell means Madam cannot talk, I think. In spite of everything, Ramani Madam is a good friend of everyone. Dr. Ramani, now you can, Madam will talk about that optimizing hormonal therapy for adolescent endometriosis. Madam.
Thank you, Sampath. Thank you for the nice introduction. Stop sharing now. I'll start sharing my screen. First of all, let me thank Dr. Host has disabled the participant screen sharing. So ask them to. I request the host to allow me to share my screen.
Ma'am, allowed है. Ma'am, कर दिया है. You can share now.
Thanks to Dr. Lakshmi Madam and
No, it is coming as the same thing. Host disabled participant screen sharing.
Okay, ma'am.
Okay. So let me thank ICOG, Dr. Lakshmi Srikande, Dr. Parag, and then Dr. Shobha Gudi for requesting me to do this very important, my favorite rather, I would say. So now let me see whether I'm able to share. Yes. Are you able to see?
Yes.
Okay. So this is optimizing hormonal therapy for adolescent endometriosis. So this is a beautiful picture. What you can see in one of the churches of Italy, where two young girls, see, they are teenage girls with pain. They are suffering from pain that is shown by the redness in the face. And in the hip, you can see the chain that is made up of thorns and apples that are symbol of infertility, and acorns are the time taken for fertility to occur, take a long time. So this means this girl probably, these two girls are suffering from endometriosis. So it's a presence of endometrial glands and stroma outside the endometrial cavity. And in adolescent girls, the stroma is much more than glandular tissue. And all of us know that endometriosis is a estrogen-dependent, progesterone-resistant, chronic inflammatory condition. This is the reason why hormonal contraception can suppress the pain part of the infertility. So the disease in adolescence, it's often unrecognized, ignored, mislabeled, and frequently it results in chronic pelvic pain, adhesive disease, and infertility at a later stage. Atypical presentation is also common. Early diagnosis and treatment may decrease the disease progression and prevent infertility. So the overall prevalence varies between 5 to 10% of the teenagers. About 25 to 50% of the girls with dysmenorrhea and atypical pelvic pain of chronic nature have endometriosis, and the onset of symptoms may be even lesser than 15 years, and they would have seen 4.2 doctors. Sometimes even they would have seen multiple doctors like physician, pediatrician, surgeon, including the psychiatrist, before they come at a diagnosis of endometriosis. And again, 50 to 70% of the teenagers undergoing laparoscopy for evaluation of chronic pelvic pain and dysmenorrhea, they do have endometriosis. Again, why this is very important? Because of the economic loss they have in the form of work loss, as well as their education is being affected, their social and sexual relationship are affected. So according to the Endocast study by World Endometriosis Research Foundation says that approximately 0.8 to 12.5 billion euros are being spent every year. Previously, we used to say 126 million women in the world, they do suffer from endometriosis, but we know that WHO in 2022 has announced that is women who are having endometriosis has reached around 200 million, and out of that 50% of the women are in India. So everybody is familiar with the revised ASRM classification and the types of phenotypes of endometriosis. That is peritoneal endometriosis, ovarian endometrioma, deep infiltrative endometrioma. So why I say this phenotype is very important, that is because the management of these each phenotypes varies slightly. Okay, then severe endometriosis is not uncommon in adolescent. About 1/3 of the adolescent girls, they suffer from severe endometriosis. So this is a literature evidence to say that this article shows that adolescent young girls are still, they can have advanced stage of endometriosis. Now, let us come to the risk factors. So when a girl has got a menarche of less than 14 years with a low BMI, and whenever there is a family history, there is about 6.9-fold time higher incidence of endometriosis among the children. And again, single important factor to say the symptom is severe progressive dysmenorrhea. And again, the next factor is school absenteeism. You can take it either as a school absenteeism or absenteeism in the work in the form of around 17 days per annum. So the entire school period among the 1 year, if the girl has taken leave for more than 17 days, that means probably she is suffering from endometriosis. And again, the most important point that has been brought about by Eva Brosen et al. Recently is the neonatal uterine bleeding, what we find commonly in the female newborns. So we routinely say that it's only the withdrawal of the maternal estrogen thing, but actually it is a pointer for onset of endometriosis at an early stage in that particular girl. So we can warn these mothers. So then comes the delay in diagnosis. I said it could be even up to 7 to 9 years. That obviously affects the quality of life, affects the future fertility, and it may be up to 7 to 9 years. Evaluation of adolescent. How do you evaluate? Because they are all young girls and we cannot go in for an invasive procedure or bimanual pelvic examination. So history that gives the clues that probably this girl may be suffering from endometriosis, and again, examination and imaging. But you see, the imaging is not very appropriate because in stage 1 and 2, you may not have the imaging evidence. Then comes the biomarkers, among which there are certain miRNA biomarkers which are gaining very much popularity. And maybe in days to come, artificial intelligence added with this biomarker may be the future for early diagnosis of adolescent endometriosis. So I routinely say the clinical symptoms are 7 Ds, that is dysmenorrhea, dyspareunia, dysuria, dysphagia, dysfunctional uterine bleeding, diffuse abdominal bleeding, pain, and then difficulty in conception. But as we are considering the adolescent girls, the most important single pointer is dysmenorrhea along with the family history. Then the probable diagnosis of early endometriosis is feasible, and ultimately this will lead to the fatigability and the depression among these girls. So this is what is a pain score or pain diary that has been proposed by Boston Children's Hospital, where again Eva Brosens have set some of the points. So if the patient has got regularity of the cycle, pain, and then how many days of menstruation, chronic lower abdominal pain, and so many other factors, they have to mark it out. And ultimately, this will give the teenage pain diary will give a clue whether this girl is suffering from endometriosis. So physical examination, see, sometimes the clinical abdominal examination and perirectal examination with the permission of the girl can be done. And we have to definitely rule out Mullerian anomaly when it is going to be a progressive dysmenorrhea, which happens in 5 to 11% of these adolescent girls. And Q-tip test is nothing but a small swab can be put in the vagina to find out whether the patient has got a transverse vaginal septum. And again, rectal examination might show uterosacral nodularity or endometrioma or a deep infiltrative lesion. Then what is known as the therapeutic trial that is being done in the adolescent girl with chronic pelvic pain and dysmenorrhea are, to begin with, we were using NSAIDs, and then comes the oral hormonal combined oral contraceptive pills. In the girl is beyond 16 years, then GnRH can be used. And again, the most popular drug is going to be the designer progesterone, that is the Dynagest, as a early treatment of this endometriotic patient. So how to optimize the diagnosis of endometriosis? This is Professor Charles Chapran, who says that there is no place for diagnostic laparoscopy or tissue biopsy. When you suspect clinically endometriosis, we can go ahead with starting the patient on either NSAID or with COC or Dynagest. So the main goal of the therapy has to be pain relief, arrest of progression of the disease, and then we have to preserve the fertility. So the concept of medical management is, because it is an estrogen dependent lesion, we have to suppress estrogen, which will reduce the retrograde spill. We know that the probable theory behind endometriosis is a retrograde spill. And again, it can overcome progesterone resistance. We need to overcome progesterone resistance, which is the hormonal basis of endometriosis, which can be done with a progesterone and anti-inflammatory. Aromatase are found to be elevated both in the tissue as well as in the central level. So inhibitors, aromatase inhibitors can suppress endometriosis, and VEGF is known to be elevated in endometriosis patients that can be suppressed by anti-angiogenic and again immune modulation. So the NSAID, as per the Cochrane database as well as the ESHRE guidelines that has been published in 2022, says that it can be safely given, just started before the onset and again the peak of the pain. Mefenamic acid, ibuprofen, naproxen or COX-2 inhibitors. But the main side effect is a gastritis. So then next comes the combined oral contraceptive pills. Mind that it has to be given for continuously, not with a break. It can give a good relief of dysmenorrhea also. Then this was an article by Professor Chapran as well as Versalini. They say whether combined contraceptives can be used very safely in endometriosis. See, according to them, what they say is it's an excellent drug for suppressing the primary amenorrhea. But sometimes what happens is the underlying deep endometriosis, example, deep infiltrating endometriosis, may be masked using that. Again, according to Versalini, he says combined oral contraceptives may be a rescue factor for regurgitated endometrial glands that would otherwise undergo necrosis and resorption during physiologically hypoestrogenic menstrual milieu. So now let us see what the ESHRE guidelines say. See, ESHRE guidelines say that combined hormonal contraceptive has got only level B evidence, but whereas the hormone, the progesterone, has got the level A evidence, and again, antiprogestins and GnRH agonists are the have the level A evidence. So what is the role of progesterone in the management of endometriosis? ESHRE guidelines, World Endometriosis Society, everybody is in favor of starting the patient on progesterone as soon as the patient complains of severe unbearable dysmenorrhea as a first-line empirical medical management. Mind that all the learned societies, ESHRE, Endometriosis Society of World Endometriosis Society, SOGC, even our FOXY, the GCPR, we have recommended the use of Dynagest or any progesterone without histological evidence. So again, what is the role for progesterone in ESHRE guidelines? That is, we can use medroxyprogesterone, either oral or depot, Dynagest, cyproterone acetate, norethistidone acetate, and danazol and antiprogestin. They all have level A evidence. But mind that danazol we are not currently using because of the androgenic side effects. So when you use progestins, around 75% of the patients experience reduction in the pain, and they are effective in treating endometriosis-associated pelvic pain. So the mode of action is it can suppress MMPs, it can suppress the growth factors, anti-inflammatory, and peripheral androgen level is suppressed, and ultimately this will reduce the symptoms. So the progestins that are commonly used are oral preparation of medroxyprogestin 30 milligram per day that is currently available, that can be used, or you can have a Depo-Provera, that is monthly injections of dipomedroxyprogesterone acetate is quite suitable in young girls with symptoms of endometriosis, and it relieves that. Then comes the Dynagest, which stands the number one in treatment of medical management of endometriosis. It is selective 19-norm and progestin activity, and then it has got anti-proliferative, anti-angiogenic, anti-inflammatory property, and it is comparable, the effect is comparable to that of GnRH agonist with a minimal side effect. GnRH, I said you have to use it only beyond 16 weeks, but a Dynagest can be used even under that. So these are the mode of action of Dynagest upon the eutopic endometrium and ectopic endometrium. It can deal with the abnormal uterine bleeding associated with this, and with all the properties like anti-angiogenesis, immunomodulatory, anti-inflammatory, and pro-apoptotic. It can reduce the pain associated with endometriosis. This is Professor Thomas Romer, who says that long-term treatment of endometriosis with Dynagest is quite safe in clinical practice, as well as Soni Singh, one of our own Indian, who has been a senior professor at Ottawa University in Canada. He is also in favor of using Dynagest for a very long time, even beyond 9 to 10 years. But at the same time, Romer has said that the combination of Dynagest with ethinyl estradiol may not be of that much effective when you treat the patient only with Dynagest. So to say scientific basis of this use of this Dynagest, Visada study has come to assess the safety in adolescent, and it is being open label study conducted in 21 centers across 6 European countries, and more than 100 girls were participants in this particular study, and the results were found to be excellent. But only thing is there was a suggestion that it could present with the patient can present with a slightly decrease in the BMD, which usually recovers once when the drug is stopped. Then comes the GnRH agonists, which are used only in adolescent girls beyond the age of 16 years. Sometimes after the continuous use beyond 3 to 6 months, we need to support the patient with an add-back therapy with either a progesterone or a calcium vitamin D3 has to be given, because it can cause sudden vasomotor changes as well as reduction in BMD. Then comes the levonorgestrel IUS, which is a hormone that is being initially the first thing why LNG IUS was used was mainly for treatment of abnormal uterine bleeding. So similarly, in adolescent girls, we have a small size LNG IUS that is called as JADES, which can be used for a shorter time, and the insertion is quite easier. So this can treat both the endometriosis associated pelvic pain plus the dysfunctional uterine bleeding. The other newer drugs are antags, GnRH antags, elagolix, which has come into vogue, and progestin antagonists, anti-angiogenic drugs like the gabergolin, aromatase inhibitors like letrozole, and then selective estrogen receptor modulator like the receptor modulators, then selective progesterone receptor modulators like mifeprin, then statins and estrogen receptor beta ligand. So this elagolix is a orally available a newer antagonist, which should be given at 150 to 200 milligram. The main advantage is initial flare-up effect is not there, as well as the reduction BMD is not so bad as GnRH analog unless it is used for a very long time. The limitation is its cost. Again, aromatase inhibitors, because the aromatase activity is both at the central, peripheral, and local levels are increased in endometriosis. It can counteract that, but again, the problem is reduction in BMD and the severe vasomotor changes. So it can be used only as a second line of drug. And some is tamoxifen and roloxifene can be used. And SPRM, that is the low dose mifepristone can be used. That is starting from 5 milligram, 10 milligram, and 25 milligram can be used. So mifepristone, onoprestone, and asoprisnil, all these are some of the drugs, progesterone receptor modulators that can be used. Then receptor ligands, they are coming up in a big way because this is the only drug which binds to the estrogen receptor alpha and beta, good anti-inflammatory, anti-proliferative effect, but all the other drugs will have a contraceptive effect, but this does not prevent the pregnancy. So again, about angiogenic inhibitors, there are so many drugs, of which gabergolin is the commonly used drug for endometriosis. Statins, they have, by the virtue of this HMG-CoA reductase activity, and they reduce the MMPAS, angiogenesis, and oxidative stress. So apart from for the reduce the lipid profile abnormality, statins can also be used, but it has to be given along with some contraception because statin is a X drug. Then gabergolin, I have already mentioned. Now comes the question of do the girls, they respond only to hormonal therapy? Do they need surgery? So surgery is indicated only when they don't have treatment, when it is not suppressed by medical management, or endometriosis that is associated with the Mullerian anomalies. Once we correct the Mullerian anomalies, the pain resolves on its own. Then again, whenever there is a rupture of endometriomas, it is an emergency situation or recurrent endometrioma not responding to medical management. So I said again, 5 to 10% of the adolescent girls can have Mullerian anomaly. And whenever there is an obstructive Mullerian anomaly, the chances of endometriosis are going to be very high. But still, in non-obstructive anomalies like the septate uterus, still you can have earlier or milder forms of endometriosis or can happen. That is because of the abnormal uterine motility. So again, it can be diagnosed by ultrasonogram, 2D and 3D and MRI, and the management is mainly the surgical. So this is a case of Herlin-Werner syndrome. A 14-year-old girl came with a history of progressive dysmenorrhea, and she was found to have bilateral endometriomas plus hematometra that has been collected because of the occlusion at the level of the cervix. And this particular patient had got a hemihysterectomy done some time back. That is now she has conceived and delivered with me. So once when this is also this Herlin-Werner syndrome is associated with the ipsilateral renal anomaly. Then this is again a very rare case of Robert's uterus where there is an atypical septum, and this particular girl was operated 3 times elsewhere without making up the diagnosis. Now you can see one horn and you see the bulging of the septum. So this is probably the atypical septum that is at the lower margin is being attached to the ipsilateral side wall. See, just by opening the septum, intrauterine septum, and draining all the fluid, the cavity can be made one, and this patient was totally relieved of the pain. So most important thing is post-operatively, you have to continue the medical management with combined OC pill or GnRH or aromatase inhibitors or DMPAs, or sometimes the patient has to be put in with the LNG IUS. So follow-up is very, very ideal, because in spite of the follow-up, the patient can, even in the expert hands, the recurrence rate is going to be quite high. So they have to be advised regarding the lifestyle modification, regarding the endo diet that has been very well given, no dairy, no refined sugar, no meat or soy products, caffeine, and saturated fats and oil. So good exercises, that is what is needed for all these patients, along with acupuncture, Chinese herbal medicines can thing. So this is ultimately my final slide, which shows what algorithm we should follow. So this is slightly differs from the algorithm that was given earlier, because now we know that we give importance only for the continuous oral contraceptive pills if the patient has signs and symptoms of endometriosis, and if the patient is quite comfortable, you follow with it. And if the patient is beyond 16 years, maybe we can try with a short course of GnRH followed by the GnRH, Dynages. So if they are relieved, continue with the Dynages, and they need, all these girls will need periodic follow-up with every 3 to 6 months. So if the pain is not relieved, then that is a place for laparoscopy, and it can pick up no endometriosis associated lesions or no endometriosis. For example, GI lesions can happen, like interstitial cystitis, etc. can happen. So that has to be addressed. Otherwise, endometriotic lesions can be cauterized, endometriomas can be managed, and then we have to, again, post-operatively, we have to continue. To conclude, empirical treatment includes NSAID and hormonal therapy. Definitive diagnosis is by minimal invasive surgery, and repeated surgery is not advised. But the current statement is there is no need for doing a laparoscopy if you think the symptoms are there, and start the patient empirically. And the most important medical management is only through hormonal suppression, though there are a lot of newer drugs in the pipeline. Alternate therapies can, like acupuncture, Chinese herbal medicine, can be tried, but you have to explain that there are only certain evidences for supporting this. But ultimately, a multidisciplinary approach with a psychological support is a must, and constant follow-up. So with all these things, if you are treating adolescent endometriosis, doing a proper follow-up, do you think that we can prevent adult endometriosis? The answer is there is no big no, because it's the nature of the disease. 30% of the patients will undergo regression, 30% they will remain static, and again 30% of the girls will definitely progress to severe form as per their genetic makeup. So ultimately, I thank the organizers for giving me this opportunity of talking on my subject that is close to my heart. Still, the ultimate point is there is no place for invasive procedure. Start the patient empirically when they have symptoms suggestive of endometriosis. Thank you.
Thank you, madam, for an adolescent endometriosis, starting from lifestyle modifications to surgery in rare cases. Final conclusion is Dynages is the best drug for adolescent endometriosis. Okay, madam. Fantastic talk, madam. No one can talk like you. Endometriosis means Ramani madam. Ramani madam means endometriosis. Okay.
Thank you, Sapat. See, one more thing is, we have come out with the Indian study of Visan in endometriosis. We just start treating the patient if they have imaging evidence or only with symptoms. But I back up with the miRNA study, and if they are found to be positive, we start the patient on Visan for a 6 months. So this is being done across India in 10 centers. Our aim is to recruit around 160 patients, but I am sure we will, because each center was given the target of 10 to 15. But within the 3 months itself, most of the centers we have crossed 15 to 20 cases. And then we are very sure that Indian data will be robust in this particular study.
Thank you, Dr. Ramani, and thank you, Dr. Sampath, for nicely concluding that. I now invite comments from the expert, Dr. Parul. I can see that he has joined, and Dr. Parag, if they have to say anything else on this talk, and then we shall go ahead. Before that, I just wanted to congratulate Dr. Ramani for having done such wonderful original work. We are very proud of you, because very few people have done original work on endometriosis from India. And we are very proud of you, especially the mRNA that you have been talking about. We look forward to that publication. Thank you, Dr. Ramani, for coming.
Thank you, Shobha. Already I have published my pilot study And now we have another study by group of experts from Asia, that is Dr. With Chapron, Thomas Romer, and 12 others. And me and Dr. Pratap was there in that study, and that has also been published. So there also the Asian consensus empirical management of these patients with dynages. That was the ultimate conclusion.
Your basket is always full of information, Dr. Ramani, more and more.
Thank you.
Can I request Dr. Parul to unmute and Dr. Parag if he has to say?
Yeah, thank you, Dr. Ramani Devi. It's always wonderful listening to you. Like I said, when when Shobha speaks on family welfare, we enjoy it. It's on the same note. When you speak on endometriosis, it really feels so simple, even though the disease is so complicated. I have two questions for you. First of all, what is your personal experience of using Dynages in adolescent girls? For how many years have you tried and have you found it useful and safe?
Sir, I think the longest period of time where these adolescent girls have been put on Dynages is beyond 5 years. I have used, and to my surprise, few of these not exactly adolescent, like premarital, like 20, 19-year-old girls coming with endometrioma of 5 centimeters on prolonged use of Dynages. The size has come down dramatically. That we have imaging evidence. So, and symptomatically, even after the first month of treatment, they are very, very comfortable. That is what our VISAL study is also coming. So we should give importance to the symptoms. Treat the symptom and not the disease is a basic thing in management of endometriosis.
But sometimes the menstrual pattern becomes very irregular with continuous use of Dynogest. What then?
I agree, madam. So for that only, when the girls are beyond 16 years, I start the patient on GnRH for 3 cycles. So get knock off everything, then start the patient on Dynages. Suppose if they have a breakthrough bleeding, stop it, then restart. And or we can add some sort of this tranexamic acid can also be added. But there are some people who say that you can increase the dose of from 2 milligram to 4 milligram, but actually that doesn't work. Instead, you stop it. You make a patient to bleed. So that means everything will get shut off and then restart. And there are other suggestions that adding up a little bit of progesterone, estrogen also. So yeah. Estrogen, maybe you can start on a very minimal dose of 1 milligram of ethinyl estradiol for a short period and then stop it and continue. Once when the endometrium gets residualized, you can stop it.
Thank you.
Or we can stop the Dynogest and put her on progesterone instead. And continuous
or a combined pill or a combined
pill.
No, Dynogest is anyway progesterone.
With norethistron and all, the bleeding will stop.
Yes,
with sometimes madam, it doesn't stop with Dynogest, but it stops with that.
Norethistron will work only when the endometrium is estrogenized. Yes. Otherwise, it is not going to work. It is still going to cause intermittent bleeding.
So they will require some estrogen. They will require some estrogen.
So that is why some group of people are telling that you can start with a 1 milligram of ethinyl estradiol, then add up that and continue for a short time. But what the discussion we had with the Asian expert group was stop it, then restart. That was the thing. Or we can add up some sort of this tranexamic acid can be added. And in patients with like adenomyosis also I use. But there I back up these patients with selective estrogen receptor blockers.
I just wanted to give a message here, Dr. Ramani. Many of these women require contraception, so they can be started on low dose oral contraceptive pills.
Yes.
I think so. I think.
Low dose contraceptive. See, that when they want contraception, I think the ideal thing will be LNG IUS.
LNG.
That is
definitely LNG is the best then.
But in a very thin endometrium, that will also cause symptoms. Can I ask Dr. Parul for his comments, because we must conclude this and get on to the next section. Thank you. Thank you, Dr. Ramani.
Well, first of all, I do compliment Dr. Ramani for an excellent overview of endometriosis. Two things. One, which you have already just spoken, Dr. Shobha, that how do you optimize which kind of combination of contraception would you use which would impact both endometriosis as well as contraceptive effect. What combination would be the best? That was
Whenever
my.
there is, we are looking at a very, very thinned out endometrium and breakthrough bleeding, we should not be opting for the 20 micrograms ethinyl estradiol. We should be opting for more traditional COCs, like second generation progesterone of levonorgestrel in combination with ethinyl estradiol 30 microgram. I think that gives benefit. That gives benefit. And later on, in the longer run, after 3 months, 6 months, when the endometrium is more stabilized, then we can start the lower dose, like 20 microgram, etc. That can be possible.
True. And long-term injectable progesterones, would they be suitable for adolescent age?
See, there is a concern about Depo-Provera or medroxyprogesterone acetate injections for girls less than 18 years. Enough studies are not there. So in case we find...
Shall I add one point, sir? This dipomedroxyproviron, this is DMPA, has been used extensively in Kolkata. Dr. P.D. Mahapatra and group, they are using it extensively for adolescent girls. Because one thing is because of the affordability of using Dynagen. And they find that it is quite all right, because once when you stop the drug, see, for normal contraception, say for a girl, a lady of 21 years, what we do? We go ahead with DMPA. How long? Maybe 5 years. So the same thing holds good. And these young girls, maybe you have to back them up with a little bit of calcium and vitamin D.
It's very true that it can be given, but we need to also understand there will be an impact on BMD. It will be reversible, but yes, other lifestyle measures should be taken to optimize the peak bone mass, because this is the time that she's going to attain the peak bone mass. Can we safely conclude the discussion?
One more observation I would like to make, that in few patients where I did give Dynogest initially, patient took it for 6 months, then on their own they stopped. And after 1 year, they had a recurrence, and then it did not work. I have shared this with the company as well.
Okay.
So what is your experience or take on this?
Sir,
Dr. Ramani.
Yeah, I will tell you, sir. See, not all patients with endometriosis respond to Dynages. That you have to understand. There are a group of people, for example, patients with a simple endometrioma, they do respond very well, or superficial endometriosis, they respond. But deep infiltrative endometriosis is one thing. I feel the response to the Dynages is quite low. On the other hand, they respond very well to the GnRH, gabergolin plus LNG, IUS. See, probably how we say that they have developed resistance to that particular drug. It could be the reason why when we are stopping and using it for the thing, it may not work.
So in your experience, have you also observed this thing?
Yes, sir, definitely. Okay. Definitely, I have also observed. So that is a situation where I change over to GnRH.
So that is something which we need to keep in mind, that it may not work second time. First time it has worked. So beware of that. That is the only point I wanted to make.
Well, I think observation is really well taken, Dr. Parul.
Okay.
So, Abhi, can I take few comments from the box before I open the next session? One of them is Madhav Prasad, complimenting Dr. Ramani for her publication. And people can read that publication and go on to it and read it. Indeed, it will be very good. And other are compliments, Dr. Ramani, for you. And I will also humbly accept whatever they have said. There is a pilot study of miRNA non-invasive diagnosis in Alamine Journal. That is by Dr. Ramani, yes. And then, are there any questions? Dr. Parag was saying there are questions which you will have to ask.
Dr. Ramani, I wanted to ask one thing.
Should be the...
Yes, madam.
Okay.
Okay. Actually, when we were students, so for the treatment of endometriosis, we were taught that you give a continuous dose of around 15 to 30 milligrams of norethistron or ethindrone, and we continue it for 6 to 9 months, creating a state of pseudo pregnancy.
Yes,
And
madam.
we used to get very good response with that.
And
So,
especially this deep infiltrative lesions,
yeah,
they are very well amenable to norethistron.
yeah,
That is
and
my
then we
observation.
keep on giving it for 6 to 9 months, and I still find very good response with
Yes,
that.
yes, madam. And again, Danasol, it is coming out in a, I mean, it's like something like a old wine in a new pot. That is, you can put vaginal Danasol, 100
Okay.
milligram of vaginal Danasol. When you put it, it also responds to deep infiltrative lesions. And the most important thing is it will not inhibit ovulation. So the patient can become pregnant. So this is one major advantage of this particular drug, which scores over the all other drugs.
Okay.
I think I must take few observation by Dr. Suparna Grover, who says that acceptance for COCs is less. And she also says that we prescribe them more often for gynae indications rather than contraception. She is very right. And I think I did put up one slide on counseling and how structured counseling can make a world of difference, and why we are unable to do it because it takes time and it takes a little bit of training how to become a counselor for family planning especially. So probably all of us should look towards having trained counselors who can help us and complement our work in the OPD by counseling women about the benefits and the sometimes the side effects of the methods of contraception. That will make a world of difference, clearing all the myths. Okay, then the other thing that she says is what should be the follow-up advice for clients being prescribed use? That is a very, very wonderful question, because I think I did not mention it. Recently, we had a panel in AICOG on benefits beyond contraception, and Dr. Ritu Joshi and myself were there. And Ritu ma'am was very clear, and I also emphasized that yes, follow-up is very mandatory, because though the incidence of thrombotic episodes is very less, it is still not zero. So therefore, we have to ask them about headache. We have to ask them about any vision changes. We have to monitor their blood pressure, any neurological symptoms, etc. So we need to have a very regular follow-up for these women. That is very correctly said. And also we need to keep looking out for any contraindications which have cropped up in the time that we have last seen her. For example, has she suddenly become a hypertensive or a diabetic, or has she developed any, or has she gone on to any drugs which will interfere with the efficacy of the COC? So thank you very much for those questions. And with that, we move on to the next session. For the session 2, we have chairpersons, Dr. S.P. Jaiswal from Lucknow and Dr. Ranjana Khanna from Prayagraj. So may I have their CVs, please?
Yes, ma'am.
Nilima, please put the approved CV deck, please. Yeah, thank you. Okay, next, please.
Good evening. Thank you so much for inviting me. Thank you,
Yeah.
Dr. Shobha,
Yes.
and Dr. Lakshmi, and Dr. Parag, and Dr. Kotwala, and a whole team.
Yeah, can I have the
inviting
next? Yes, ma'am, let me introduce you, Dr. Shyam Pyari Jaiswal. I love speaking out your entire name, and I really like it very much. She is the professor and unit head, Department of OBG, KGMU, Lucknow, and that is not a small feat, because it indicates the so many years of service that you have put up for that institution. You are very richly decorated, so many awards. You are also the fellow of ICOG. You are a visiting professor at BP Koirala Institute of Health Sciences, Dharan, Nepal in 2008. And you also won the visiting professor for ICOG visiting professorship. Very warm welcome to you, Dr. S.P. Jaiswal, ma'am. Next,
Thank
please.
you, Shobha. Actually,
Next.
this is my old slide. And
Yeah.
now I am head of the department.
Yeah, वही मैंने सबसे पहले वही बोला कि you are the head of the department. Yes.
ये पुरानी है लग रहा है.
ऊपर है ना, देखिए.
Unit
Okay,
head
next,
लिखा हुआ है
please.
ना? I think it's
हाँ.
the old one.
अच्छा, नहीं, मैंने HOD बोला. मैंने नहीं बोला
Thank you
HOD.
so
She is
much.
heading the department. Yeah.
Thank
Dr.
you so
Ranjana Khanna, our very dear ma'am from Prayagraj, the one who conducted that most, famous dilemmas in obstetrics, and we thoroughly enjoyed that innovative
Thank you
conference.
so much.
Welcome, ma'am. You have been the vice president of Foxy in 2017, very unassuming, very modest and humble person. And she is the founder president of Prayagraj chapter and ICOG governing council member at present, 21 to 23 with me. And she has been the president of AOGS 2013 to 16. Thank you, ma'am, for being here, and most welcome to you. So I request
My
now
pleasure,
the
my
chairpersons.
pleasure.
Yes, I request you to introduce the first speaker. One of you. Thank you very much. Please share the next slide. Dr. Jaiswar, please introduce.
Yeah.
Yeah.
I'm feeling privileged to introduce Dr. Madhav Prasad. He is MBBS from Bangalore, MS from Mumbai, and DNB also. Having postgraduate diploma in medical legal sciences, and there's other also there's so many graduate diploma. And he is a national corresponding editor. Along with he's a joint assistant secretary, and he's having lots of things in his credit. He's going to speak on the importance of contraception among the women with medical disorders. Definitely, this is the point.
He is the associate professor at Vaidehi Institute. That's all.
Where it is written, I am not able to see it.
Right side. On the right side.
Right side. Yeah. He's an ex-assistant professor. I'm correct, Dr. Madhav?
Yes, madam. Thank you, ma'am. I'm associate professor at Vaidehi and I was in KEM before. Thanks
so
a lot for that
you have not
introduction.
updated your CV, I think so, like me.
Okay.
This is an
That's fine,
ex-assistant professor.
Okay.
Nice.
Right.
We all keen to hear you. And this topic is really important. It's a topic of very controversial also, because once the patient is having medical disorder, in that situation, we have to think which type of contraceptive we should give. So he is going to enlighten on this. Dr. Madhav, please.
Yeah, is my screen visible?
Yes, sir.
Yes.
Yeah, right. So we had two interesting sessions. This is going to be a little light on y'all. Basically, the concept which was proposed was that we will look into one publication which was done on the topic of family planning. And this publication by me highlights the importance of contraception among women with medical disorders. So the average life expectancy among women has been gradually increasing. It is a well-known fact. Over the last many decades, the average year has been increasing, not only in India, all over the world. Now, so slowly there is a transition from survival to quality of life. So what happens? There is increase in longevity. Case fatality rates of many major disorders are reducing, and diseases of which patients were dying, cardiac, renal, liver disorders, thalassemia, all of them have now come to reasonable longevity, and reproductive concerns come into focus. So initially survival itself was a problem. Now quality of life is improved, and now reproductive concerns come into focus. So on the other hand, there is a huge burden of unmet need of contraception. So in this unmet need of contraception, when we look into the patients with medical disorder, it is a significant number also. Now, what happens when a woman who has been having a medical disorder, treated by a physician, treated by a super specialist, ends up with a pregnancy? The treatment success of major medical disorders can be destroyed because of the occurrence of pregnancy. Cumulative efforts of a physician or specialist or super specialist can become, nullified, and this again leads to intensive care requirement, etc. All of us are very conversant with the fact that patients are required with major problems for MTPs, for obstetric care also. So if you look at this vicious cycle, patient was initially following up with a physician super specialist, something was missing, pregnancy occurred, referred for MTP, and the cycle continues if we don't stop it. Now, what is this? This is obviously what we are going to be talking about today. Now, WHO MEC, there is most of us are familiar with this. That is, there is a large basket of contraception available to us, and this kind of physician-friendly documents, that is the WHO MEC guide or a chart, is now available as apps also. We can just download this to our app and we can just click whatever the patient is on, whatever the medical disorder the patient is suffering from, you just click and it will tell you which is 1, which is 2, which is 3, which is 4, which is most suitable, which is least suitable, or which one has benefits. I'm not going into the details of this, but just to highlight that these are easily available and it does not require an OBGYN training to use these kind of tools is the main point. Now, despite the availability of all these things, it's a very sad reality what high-risk patients continue to come. If the patient and the physician knew that she suffered from medical disorder, why was the pregnancy even allowed to occur? This begs the answer to the research question: what is the knowledge level, attitude, and practices by physicians regarding contraception? First, let's look into this was my publication. First, the literature review. So what happened? Bonassi says there is a lack of studies dealing specifically with contraceptives for women with heart disease. This generates doubts whether physicians are actually counseling patients about the problems of medical disorders. Then French et al. Said even patients with chronic medical conditions necessitate, like even those who were having solid organ transplants were not aware about contraception. Gavron said patients with inflammatory bowel disease, they are at risk of adverse pregnancy outcomes. We know that, but they look out to the gastroenterologist for contraceptive counseling, but gastroenterologists do not bother about it at all. Similarly, heart disease, adult congenital heart disease, it was found that more than 50% of the women had not received either contraceptive or reproductive counseling. And it said that a stronger collaboration among healthcare professionals is needed. So with this background, a study was conducted after IEC clearance. A Likert scale questionnaire was developed after validation, and it was administered to the doctors working in the tertiary care hospital. The questions were as follows. First, initially, the questions were to ascertain that they are indeed seeing a lot of patients, how frequently they saw patients, and have you ever referred patients for MTP, etc. Then they were asked to grade. Advice regarding reproductive issues and contraception is mainly the responsibility of the gynecologist. I have always taken menstrual history. I have always taken contraceptive history. I have ensured that multiple medications for any chronic medical condition get contraceptive advice. Overall health can be benefited with contraception. And what is their practice? Do they always send a patient for contraception to gynecologist, or they do it themselves, that is. So, and knowledge, do they know what WHO MEC means, and their opinions regarding improvement? The results were quite surprising. So over 1 month, we interviewed 45 physicians, around 6 years experience. 82% had encountered patients with medical disorders, so they were an appropriate audience. And 98% had referred at least one patient for MTP for purely a medical reason. Now, for this statement, advice regarding contraception is exclusively to gynecologists. 82% disagreed, which means there is an indication and willingness for collaboration of in the matter of contraception between physicians and gynecologists. Now, menstrual history was always taken, only 16% missed it, but 55% missed taking a contraception history. And the senior physicians were performing better than the juniors. With respect to practice, only 4% were referring all women to gynecologists for contraceptive advice, and 36% were referring only if the patients asked for it. So we asked the question, do you think the overall health of a woman will improve with contraception? 100% response to the item. And a dismal 6 out of 45 were able to expand MEC correct. And starting of specialized contraception came up as a prominent suggestion. Now, it's a small study. It has looked into the knowledge of physicians regarding contraception quite objectively, and a lack of knowledge and poor practices demonstrated. Like, even though it is not expected that physicians recall accurate options for contraception, they should be able to use customized charts or applications and use the appropriate devices. Now, through this study, I recommend that there should be specialized contraception clinics, and there should be close coordination between OBGYNs and physicians. And for the entire success of the family planning and contraception, it has to involve other specialists also. This was what we tried to tell through the study. Now, what is the implication of this study to the OBGYN fraternity? Why should we be discussing this at all? This is what I think. We OBGYNs need to reach out to our physicians counterparts more actively. It can be done at individual level also, colleagues, spouses, friends, whatever. We should strive to find place in their conferences, medical updates, CMEs. A 10-minute talk on contraception to them would make a definite impact, so that we can clearly drive home a message. Please ensure your high-risk patients are time benefit of contraception. This will ensure the last mile connectivity in the topic of contraception among women with medical disorders. That was my last.
I think you can stop sharing.
Yeah.
Yeah, I think the study was worth its weight in gold. I can't be, more expressive. You have brought forward the concept of integrated care to its full, full limelight. What do you say, Ranjana ma'am?
Really, this study is eye opener. Sometimes this is maybe the simple things, but we don't bother about. Definitely in the contraception field, the counseling has very importance, one thing. Second thing is the contraception is different for the different age group and different patient. We can't say word patient, they are women having different type of problem. So it should be definitely should be specialized, like the patient who is having cardiac illness, who is a diabetes, who is having stroke. In that situation, she needs proper evaluation of the case before giving the contraception. So your study is definitely is wonderful, and I think nobody has bothered about to think as, and definitely not me. I have never thought of if we can do study on that, and really it needs study, because in our now as the age is increasing and in the fertility, although there is a late fertility because of the carrier and the people start late, and sometimes there is a accidental pregnancy also, in that the woman suffers a lot, whether should go for the termination or what to do. So these are the things which should be tackled properly. Yes, your talk is definitely wonderful, and you have supported with the study. Ranjana ji, do you want add something? I really happy to listen this your talk. Different from the routine. Otherwise, I thought you will give idea about the cardiac patient should take this one.
वो सबको पता है.
But that is all there in the MSc wheel. Now it has become so common to see that. But yeah, this was a different insight. And of course, we have to really counsel. I have seen that the role of counseling is really very important where contraception is concerned. And I don't know about when I was in the hospitals, then we used to put a lot of IUCD. In fact, my thesis topic was on copper T only. So, but now I have seen that more and more people, at least my patients, they are taking up DMPA, and very well. And you just have to counsel them that don't be scared when your periods become irregular, you will not conceive. And so they take it very well, because somehow at the back of the mind, though it may be very small invasive procedure like putting in an IUCD, but there is a little bit of apprehension about that also. So it depends from patient to patient and how you counsel. So some time has to be taken out on this family planning counseling. I think that's really very, very important.
Thank you, Ranjana ma'am. I would like Dr. Lakshmi's comments on the paper. I hope that she was here to listen.
Yeah, she's here, but she's on the phone, I think.
On the phone. So I wanted to check with Dr. Madhva that whether we can, whether has he thought about a kind of a follow-up after the initial one, so that he can see the difference in perspective after an interval. Yeah.
Yes, ma'am. So the thing is, there is even while we were administering the questionnaire, there was a lot of resistance to even answer these things, because we were obviously asking some questions which was, quote unquote, exposing ignorance.
Okay.
So,
I thought you will say patient confidentiality. Okay.
No,
Mhm.
this was directly
Directly their own
about,
knowledge testing. Yeah.
it was their own knowledge testing. So in fact, there were a lot of people who even said, no, we don't want to answer. They just rejected. So, you know, so it's very difficult to
Because
convince.
I have learned, Madhva, that people generally don't like learning about family planning and contraception.
Yeah.
And
So
we have to kind of be very intrusive and push our way in and teach them. Dr.
Correct.
Lakshmi, your comments on the talk.
No, it was too good. I mean, the deliberations going on. In fact, I am learning a lot. That is what I can say.
Dr.
Great
Madhav,
learning.
how you have taken confidence to this consultant? Ask
I'm going
about
to-
that.
Dr.
Because
Jaiswar is mighty impressed with you.
really, sometimes because counseling of the patient is different, but counseling of doctor is another thing.
Shobha, actually, it is the cold which is hitting us very hard.
So it is actually difficult to walk to a senior
Honestly.
consultant and say,
Correct.
are you doing this? So
Very
imagine.
intrusive, correct.
So
But
it's
it was
quite intrusive.
needed. I feel it was needed. I
so
think
in
he has
fact-
done something very courageous, and
Yes.
I compliment him for this, and I want him to continue the good work. If I
So-
had known, you know, I would have taken this idea into my committee work. I didn't know that you were doing this.
So
Very good.
my message to the seniors in Foxy and ICOG is, we have to officially infiltrate their conferences and say, you know, just this is the finding.
Absolutely
So
right,
we-
Dr. Madhav. Still, you can give and share your ideas with us all. And from ICOG side, we will try to do that.
Definitely.
I mean, we are academic wing, so we are there to teach not only our own colleagues. We are
And-
there to teach all the other specialties as well. And when it comes
Yes,
to contraception, why not? I will say, why
Exactly.
not?
Yes, ma'am.
Actually, this is need of everyone, because
Yes.
this is the contraception is not only the area of gynecologist.
Yes.
That is why I said integrated care is so important. Every woman who walks in should be tapped for her unmet need for contraception. Every woman. And
Definitely.
definitely she will go to other specialists. And definitely gynecologists are the best people to tell them that you need to tap for the unmet need. So,
So, Madhav, we will ask for 1 hour ICOG session or half an hour ICOG session on family planning in their conferences.
yeah.
Definitely.
Good.
Correct.
Yes.
In fact, Dr. Lakshmi, I must share that in the second year of my performance, I did float a concept of Jagrati. Still, we did it as community awareness, but we tried to do sessions with IMA and physicians, Association of Physicians, so that, we can give some talks and raise their awareness.
Now we have evidence.
Yeah, now
Madhav,
we
I will
have evidence.
definitely
You gave us
explore,
the
and
evidence,
if
Madhva.
it materializes, I will definitely remember you and Dr. Shobha Gudi to conduct those sessions. I got an idea now. So
Thank you
I'm
so
going to
much.
explore it seriously.
It
and
is called
sincerely.
cross specialty talks.
Yes,
We can
yes.
have that
Yeah.
cross specialty sessions, and ICOG will become very, very, very famous if we do
I'm
that. That is there in every branch, in oncology,
sincerely and
in
seriously, I'm
endocrinology.
exploring Shobha.
Yes, that is great. That is great.
I also feel, Madhav, I also want to conduct this study in my institution to involve.
Please do. You please do. It will
department
add to the
people.
evidence.
Validated
Of
question
course.
is ready, ma'am. Please take.
Correct.
Yeah.
Thank you, Madhav. You really brought lot of new thought into the webinar today. Thank you so very much. God bless you, and may you continue your great research work. And I hope that you come into ICOG in a more structured way. Thank you very much.
Looking
We
forward.
go on to Dr. Kavita Agrawal. Can Dr. Ranjana
Yeah.
ma'am please?
Yeah, can I have a CV? Though I've known her for such a long time, when I did my in my vice presidential year, when I did my Foxy BOH, and Dr. Rishikesh and Rishma requested me to do it in Delhi. So it was a challenge for me. And I used to trouble Kavita so much. She was my scientific person, and I used to keep on ringing her up in the dead of night sometimes. Kavita, no, change this speaker now. This one is that, and that one is this. Poor girl, how much she went through. So Kavita is now associate professor. I think then also you were, right? Yeah, it's VMMC and Safdarjung Hospital, chairperson in fertility subcommittee of AOGD, vice president IMA South Delhi branch, and she's national corresponding editor Jogi, and organizing joint secretary. Yes, she was Foxy BOH Conference 2017. That's precisely what I've been talking about. And has more than 50 publications in various national and international journals. And we would love to hear the clinical pearls, Kavita, that you want to talk about.
Thank you, ma'am. Thank you for your kind words. And it was really a pleasure and a memorable time, which
Really, that was really good.
I would just like to share the screen.
Yeah.
So thanks, Shobha ma'am, for making me a part of it. I would just like to put it on slideshow. Yeah. So I hope my slides are visible.
Yeah, yeah.
So I'll be talking about the clinical pearls on contraception. Basically, there are some case scenarios which we normally face in our OPD or when we are on call and the residents call ma'am what we should do in such situations. So I've just tried to put those case scenarios which you can think over, and then I will add clinical pearls to it. So starting with the first one. That is, a patient had given consent for cesarean section with postpartum IUCD insertion. But a resident doctor on duty was doing cesarean. And since morning, she was busy in cesareans, one after the another. And finally, she closed the abdomen and forgot to insert copper T, trans-cesarean. So now what option is available? Can this PP IUCD insertion be done vaginally immediately after cesarean? Can it be inserted vaginally within 48 hours of cesarean? Provide any other contraceptive method and can follow up at 6 weeks for IUCD insertion. So these are the various options that resident gave me on phone, ma'am. What should I do now?
Audience can respond by typing the number, option number.
Yeah, if you just want to, you can try it. So I move forward. So the answer is that provide any other contraceptive method and can follow up at 6 weeks for IUCD insertion. And this is my clinical pearl number 1. That is the procedure of PP IUCD insertion when we are talking trans-cesarean. It is actually maneuvering with the instruments, and straightening of the uterus later may cause damage to the stitches because now you have put the stitches. It's not a vaginal delivery, it's a cesarean. You have just now put the stitches, and now if you handle it with instruments, there can be damage to the stitches leading to infection, pain, and moreover, maybe you have done it an elective cesarean. So maybe the patient is not in labor, the os is closed, and you might lead to traumatic. So it's always only trans-cesarean, means trans-cesarean. If you have closed it, call her after 6 weeks.
Kavita, Dr. Rachna Chaudhary and Poonam Kumari have given the correct answer. Next.
Okay. So we move on to the second scenario. She's a 26-year-old, para 1, live 1 abortion. Immediately she conceived after copper IUD removal. But unfortunately, she had a vesicular mole, got evacuated 6 weeks back, and is on beta HCG surveillance. The beta HCG level is 2000 international units and is showing the decreasing trend. She requests the doctor for an IUCD. So now what is your take on it? It many times happen. I think it's a very common condition what we have observed, that as soon as the patient gets the copper IUD removal, they conceive immediately. So now what will you do? Will you give her an IUCD or not?
I
Yes
have 2
or no?
responses for B. 3 responses for B.
So that
You
is
can go
very
ahead.
correct. And that is clinical pearl 2. That is, if we go through the MEC criteria, although this has been discussed in all the previous lectures, but just a few things in the form of case scenarios. That is, use of copper T is not recommended as heavy and prolonged menses, benign trophoblastic diseases at high risk of STIs, AIDS patient not on ART, and 3rd degree UV prolapse, VVF. And if we particularly see gestational trophoblastic disease, that is IUCD, which is what we are not recommending. COCs, implants, oral, basically oral injectable implants, in which you're not putting inside the uterus anything, and all those contraceptives can be given. Coming to the third, my DMPA injection is due after 2 weeks, but I am going to my village. This is what the patients actually come to us saying. Sometimes they come early, sometimes they come late to us. कि मैं गांव चली गई थी, अभी वापस आई इसलिए देर हो गई, या मेरे को गांव जाना है, तो मैं क्या करूं? अभी my injection is due after 2 weeks and she won't be able to come on the scheduled date. So can I take injection DMPA today itself, that is before going to the village? So it can't be given before the scheduled date. Second is, yes, it can be given, but follow-up date for the next injection remains according to the previous schedule. Yes, can be given 2 weeks prior, and follow-up date for the next injection will be 3 months after the present injection. So what do you think about it?
Everybody has answered
prior
same.
also?
Yes.
Yes, it can be given 2 weeks prior, but the follow-up date for the next injection will be from the present injection. It won't be scheduled according to the previous schedule. So that is pearl number 3. That is the DMPA has a grace period. Pre-grace period before injection is 2 weeks prior. And if I talk after the scheduled date, it is 4 weeks after the scheduled date. So if she comes 2 weeks earlier than the follow-up date, will be calculated 2 weeks earlier from the next follow-up date, and 4 weeks later if she comes 4 weeks later. That is just by the present injection, you have to calculate her date. Now coming on to the fourth scenario, a 20-year-old woman has recently been diagnosed having a seizure disorder and was started on carbamazepine. She is already on combined OCP since the last 2 years and is having regular menses. But now she had breakthrough bleeding, so she got worried. When she came to the doctor on pelvic examination, no cervical or vaginal pathology was revealed. What would you like to advise her? She should continue with OCPs. She should switch on to some hormonal. Can she switch on to injection DMPA? Or now she can only take non-hormonal contraception? So what do you think of such patients? So the answer is we can switch to injection DMPA. So that follows clinical pearl number 4. That is, it is mostly said when you're doing the enzyme inducers, do not give hormonal because it will reduce the effectiveness. But it is with OCPs. Injectables is going to be an appropriate choice if she really wants to go with a hormonal method, as no reduction in the contraceptive efficacy of injection DMPA has been reported in women receiving concomitant drugs that induce hepatic enzymes. So she can go for injection DMPA, but yes, not OCPs. So now coming to 5, that is 24-year-old para 1 live 1. She wants to use copper IUD, but she also reveals the history that she is having pelvic tuberculosis or genitourinary tuberculosis and is on a 4-drug regimen, that is isoniazid, rifampicin, parazinamide, and ethambutol. Now, what would you like to suggest her? Can she go with copper IUD or not? Earlier, when the patient was on enzyme inducer drug, we said only no to OCPs. We said she can take injection DMPA, and in fact, all non-hormonal she can take. But now what? She is on rifampicin, an enzyme inducer, but also she is having pelvic tuberculosis. So here the answer will be no for even non-hormonal copper IUD, and that is the pearl number 5. That is, if I talk about pelvic tuberculosis, if it would have been pulmonary tuberculosis, then I would have said yes to copper IUD. But as she's having pelvic tuberculosis or genital tuberculosis, then it becomes a no-no to copper IUD or LNG IUD. But if I talk about the enzyme inducers, then again COCs and POPs, they become no to it. So best for her will be again injection DMPA, because it covers both the points here. Earlier, it was just an enzyme inducer, but now we have genital tuberculosis along with it. So now IUD also becomes a big no. So moving on to 6th, a 17-year-old girl, sexually active on COCs, she came to family planning OPD. While taking the history, she said that she has occasional non-migrainous headache. That is, it is not due to migraine, maybe due to eyesight or something else. But see here, it is non-migrainous. What will you advise her? Can she continue COCs, or she needs to switch over to other contraceptive choice? So that was, I think, very well discussed with Shubha ma'am also, that she can continue, and that is pearl number 6. That is for non-migrainous headache. We don't need to worry. If there is migraine without aura, we have to think before giving COCs. But if it is migraine with aura, then we are only left with non-hormonal method. So as it was non-migrainous, she can use anything. Nothing for her, nothing is contraindicated.
Kavita, can I add a little bit
Yes,
here,
ma'am, please.
Kavita? The thing is, I think we need to understand that migraine with aura is a severe type of neurological illness where women have higher risk of stroke. And the control of the original disease is very, very essential. And we must kind of avoid anything which will precipitate. And I can see one hand raised from Dr. Nalini. Do you want to contribute anything, Dr. Nalini, or shall we go ahead and in the end we'll take your, because there is a chat in which also you can post. Okay, right now there is no response.
Okay, so we go on to question number 7, as now it's a COVID era. So I think we should actually talk about at least one pearl related to COVID. So is it safe to take COVID vaccine and injection DMPA at the same time? What do you think? Yes or no? Can she take it at the same time?
Yeah,
So-
responses are there, yes.
Yeah,
Yes.
answer is yes, and that is clinical pearl number 7. It is safe to take both the vaccines and the injectable DMPA at the same time. It just that it should be taken on different arms. Alternate site can be used, like buttock and outer part of the thigh may also be used for DMPA. COVID infection or vaccination neither decreases the effectiveness of contraceptives nor increases the side effects. Now coming on the last 3 pearls on sterilization. After covering the whole of, I've just included 2 to 3 on each of the contraceptives. So laparoscopic tubal occlusion, can it be performed concurrently after 2nd trimester abortion? True, false, no, but can be performed within 7 days. If infection is ruled out, none of the above. So here you have to see the 2 things what I've included. That is, one is laparoscopic and second is 2nd trimester. So that follows the pearl 8, that is false.
Very, very mixed response this time.
Yeah.
Yeah.
So I specifically, that's why I said when we are
Can
doing
you go back? Can you go back and
Yeah,
explain
go back
all
to
the
the,
options?
yeah.
So when you are doing laparoscopic ligation, it is good with 1st trimester, because in 2nd trimester, the tubes are a bit thickened, and after that, there can be slippage of the rings. So that's why if you're putting the fallope rings, it is always said you do laparoscopic only with 1st trimester. If
And
you're doing
uterus is
2nd,
also slightly bigger, right?
Yeah.
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 So if you are doing it with 2nd trimester, better to go it open rather than laparoscopic, mini lap. So I move forward with that. So during laparoscopic tubal ligation, surgeon was not able to identify one tube and thereby could not ligate it. I repeat here, I'm talking about laparoscopic ligation. So you do not have the histopathology with you. Whatever you are seeing, you are doing. That's it. So during laparoscopic ligation, surgeon was not able to identify one tube and thereby could not ligate it. So which is correct? He ligated one side and he was sure about it. So ligation certificate to be given. Ligation certificate with mention that only one tube ligated can be given. A ligation certificate to be given with mention that patient not eligible for compensation as only one tube is ligated, or you're not going to give the ligation certificate.
Very
Not
sure
giving.
response. I think many have responded as D. Many have
Yeah.
responded.
Should not give the certificate.
Yeah, we should not give the certificate
Please go
unless we
back and
identify.
explain each. Go
Yeah,
back and
I
explain.
will just explain it.
Yeah.
The sterilization certificate should not be issued if surgeon is not able to identify the tube on one side and thereby could not ligate it. However, if you have ligated, but if you are not sure about it, then what we do, we issue the ligation certificate after hysterosalpingography. We say after HSG. That is, if the patient wants a sterilization certificate, we will do an HSG. Maybe after 6 to 8 weeks, whenever she wants, we can just do an HSG and see if both the tubes are ligated. If we are not able to trace it till the fimbrial end, but if we have ligated both. But if you have not ligated both, then definitely you are not going to give the ligation certificate, because such case of ligation certificate, if given, that means you are making them eligible for compensation for failure under indemnity scheme. So not ligated both, not eligible for certificate. But yes, if you have ligated, but you were not able to trace the tube, then you can say ligation certificate to be given after HSG.
Yeah.
Because it is laparoscopic. You don't have the histopathology with you.
Yeah. Kavita, can I add a clinical
I
point?
Yes, please. Yes.
Yeah. The clinical action also needs to be taken here, because the woman remains susceptible for a unplanned pregnancy.
Yeah.
So she needs to be given another contraceptive method.
Alternative.
Till the husband can undergo a vasectomy, because
Yeah.
I think here the husband should be advised to undergo NSV if they desire permanent. We should not make another attempt for her. Preferable that husband till such time she can use a LARC method like an IUCD or implant or DMPA. The other thing I want to tell you is that the clinical step taken alternative, and the fact that she has not received a compensation even after undergoing the procedure should be explained to the family. They will be given the incentive, though. The incentive will be given. What does government say? Will they be
Yes,
because
can I
there
add
is
something?
incentive
Yeah.
and there is indemnity. Both things are different.
Yeah.
We can give incentive, but we cannot give certificate. Even
We cannot
the
give.
certificate should
So
be
as
given
long as
after
they are
first
paid and
menstrual. After that, when she finished her menstruation, means we have to confirm she is not pregnant, even during that cycle also.
Correct. But I think we have to clearly give a certificate saying that if there is, sterilization procedure could not be completed. Very clear. It should be
And
written
that is
somewhere.
in the form.
Should
If
be
we
written
see
in
the
the notes somewhere.
sterilization,
Yeah. Don't give a certificate.
Don't give.
Why should you give a certificate?
Mentioned in some kind of
No, ma'am,
discharge
ligation certificate we cannot give, but
We
yes,
cannot give.
in the sterilization form, the consent form, there's a separate form attached with it, which says that why you were not able to perform and what is the alternative contraceptive method you have advised to
that
the
has to be completed. That
Yeah.
documentation. Excellent point, Kavita. That's
Very
why I wanted
nice.
to discuss it further.
Yeah,
Thank you
yeah,
so
yeah.
much. Go ahead. Go ahead.
So we come on to the last. That is, now we are talking about the open ligation. So 30-year-old female, para 2, live 2, had cesarean with bilateral tubal ligation 3 weeks back. She comes with the histopathology report of fallopian tubes and is having lactational amenorrhea. Now, which is correct? Ligation certificate to be issued. Mind you, we have done bilateral tubal ligation, and she is having the histopath report also. So ligation certificate to be issued, or to be issued if UPT is negative, that is pregnancy test is negative. A ligation certificate is not to be issued in lactational amenorrhea, none of the above. So
I think it can be issued. What's the problem?
I'm not able to agree with the responses, and Sorry, I
Okay,
cannot
so
agree
I
with
move
Ranjana ma'am
further
also.
with it and just clarify the few things, because these are some things which we have been facing, because in Safdarjung we are doing lot of ligations, and then the people when they come for compensation. So these were some of the issues which we are facing in our daily practice. So I thought of putting all this here.
Yeah, please.
The answer is none of the above. Basically, the ligation certificate is not to be issued. So that
But
is
you have
clinical.
all, but Kavita, you've already done the ligation.
Yeah, but it is only
Ma'am,
3
I'm
weeks
talking
since
about the
ligation.
certificate.
Yeah, certificate cannot be
Certificate. I
given.
will just explain why not.
Yeah, correct,
Mm.
correct.
So that is last clinical part. Certificate of sterilization should be issued 1 month after the
Oh.
surgery. She
Oh.
came after 3 weeks. That
Hmm.
is one point. Or after the next menstrual period.
She
So
was
it is that,
amenorrheic.
yeah, maybe she was lactational amenorrheic. That was not a problem. But if she would have come after 4 weeks or after 1 month rather than after 3 weeks, we would have done the urine pregnancy test and could have given her. But she came at 3 weeks. That
Hmm.
was the thing.
Kavita, I think in my talk I said highly sensitive UPT within 3 weeks will, cannot be relied upon as negative. I already
Yeah.
said.
That is why 1 month. That is why.
Understood.
That is why.
Or
that
next
is why.
period or
Yeah.
after period.
Or
Yeah.
after the period, yes.
1 month after the surgery or after the next menstrual period. It can be any one thing. It's not that if she's going to breastfeed till 2 years, then she's not going to get the certificate. No. So anything 1 month after the surgery or after the next menstrual period. Second is, if client does not have her periods even after 1 month, that is what I'm talking about, lactational amenorrhea, just rule out pregnancy by urine pregnancy test before issuing sterilization certificate. Now coming on to histopathology details. Histopathology report of fallopian tubes is mandatory in cases of mini lap and postpartum. I'm not talking about lap ligation here. The pathologist should report fallopian tubes with comment on lumen of fallopian tubes. This thing I want to bring into the notice, because in one of our patients, they said that the pathologist has not reported that the lumen is seen. So from that time, we have been asking our pathologist, and now they are giving us the report with clearly saying that this is suggestive of fallopian tubes and has lumen in it.
Oh.
That is what they want.
I think here we can add that if a complete transection has been performed, then lumen will be there. And if it is a partial one, or if it is some other structure, lumen is not there, chances of recanalization and failure are higher.
Yeah.
And they also do not give compensation. So they want the histopathology report when the file goes to there for the indemnity. They see the histopathology report, we have to attach it, and there should be lumen of fallopian tubes. And sterilization certificate should not be issued if the surgeon is not able to identify tube of one side and thereby could not ligate it. Also, such cases are not eligible for compensation for failure. So that is what the previous one also. So thank you so much. And I would just like to say risk associated with unwanted pregnancy are always higher than the risk with the use of any contraceptive. So please give contraceptive to the women.
Yeah, I think that was a brilliant talk, Kavita, and I think all of us were spellbound. Our minds did not wander. We were just listening to you, and you have brought out really the clinical pearls. Your words were actually pearls only. And again, I think that seeing all your pearls, again, it brings back to my favorite type of contraception, which I am prescribing so much and using so much, and that is DMPA. Because I am having brilliant response with that. So, that is one thing I really appreciated, that you brought out those small details about the sterilization and when and why we should give the certificate of sterilization. So that is very important points. And they were not pearls actually, Kavita, they were diamonds.
Congratulations, Kavita. Really, you have emphasizes the all practical point. These are the
Very
practical
nice.
point and
Very nice, Kavita. I really appreciated it a lot.
Yeah.
Ranjana
Nice.
ma'am, when we did our Foxy Sankalp with all the states, that time this segment, Clinical Pearls, used to be the most favorite. You know,
Yeah,
people used to wait for this.
Yeah,
And,
this is excellent.
Correct. And Kavita and another faculty from Karnataka, Radhika, both of them used to do it so well. Thank you so much, Kavita, for
Very
bringing
nice.
in so many different aspects. I
Yeah,
agree
yeah.
with Dr. Anita Rajoria has
Lovely.
responded that, you know, it is important to have complete transaction in during tubectomy, and to draw the okay. I again reiterate to draw the procedure in fallopian tube loops of open female sterilization. Okay, that's what she is emphasizing on the technique. Good, Anita, you can also you know, display your video and come on, not a problem, you can join.
Yeah, and you know, it's not like if you don't actually remove the in totality the tube, that is when the failure occurs, and often then we again face problem that you had ligated, then how come? So
you
we have to be very
yes ma'am. Today, Dr.
There may
Lakshmi,
be
I am
difficulty.
particularly very delighted that the chairpersons also have really enjoyed the talks and they have also interacted so very well.
Yeah, thank you so much, Dr. Lakshmi and Shobha, for the invite.
But Shobha, your
Thank you. Thank you, Dr.
your
Lakshmi and Dr.
topics and
Shobha.
speakers were simply, I mean, your choice.
I know, and I was chairing the session
Full
of my
credit
favorite
goes to
girls.
you.
Thank you, sir.
Thank you, sir.
It was really very interactive and very, very informative.
Very nice, very nice.
2 hour
Yeah.
session. And icing on the cake was Dr. Kavita's clinical.
Oh yes,
Thank you.
clinical diamonds, as I would like to call it.
Thank you.
Yeah, actually, we must have some kind of family planning, maybe from
Yeah.
ICOG campus
Yeah.
or something, in which we can bring in all these interesting things.
I
Very
think,
interesting.
yeah.
I would place a request to the chairperson to allow us to do that. And you can only handpick as we go along the Sankalp webinar who all should
Yes.
contribute. And at the end of
Yes.
6 months, we can have something.
Great,
Yeah.
great idea.
Yeah.
Thank you so much. Yeah.
Thank you so much.
Thank you.
Komal,
Thank
you
you,
can
Shobha.
stop recording. Yeah.
Yeah.
Okay,
We can
ma'am.
give the formal vote of thanks. Just a minute,
Yeah,
Nilima.
just a minute.
Can
Go
just
for it. Yeah.
formal vote
Okay,
of
ma'am.
thanks.
Yes,
Yeah,
ma'am.
just 1 minute more. And if the chairperson has already, she has given us a lot of praise. We are thankful for her presence throughout the session. I think she will have so much more on her plate, but she has taken time out. So my first thanks goes to Dr. Lakshmi Srikhande. She has been a wonderful leader in the past 2 months that we have seen her, and very inclusive in her planning and very insightful as to what needs to be done to bring forward ICOG in a big way as a complementary body to Foxy. My sincere thanks to Dr. Pai and Dr. Madhuri Patel, though they could not be present. Their entire support is there for all ICOG programs, including the Sankalp webinar. My thanks to the secretary, Dr. Ashok Kumar, who was not present, but then he has always supported our endeavors. My thanks to Dr. Parul and Dr. Parag again for being the experts in this session. And I immensely thank all the 4 chairpersons, Dr. L. Krishna from Bengaluru, Dr. S.P. Jayaswar from Lucknow, Dr. Ranjana Khanna from Prayagraj, and of course, dear Vice President, Dr. Sampath Kumari from Chennai for being present throughout. I really applaud the speakers today, Dr. Ramani Devi, Dr. Madhva Prasad, and Dr. Kavita Agrawal. Fantastic contribution by all 3 of them. And I thank the audience for their wonderful interaction. Last but not the least, many thanks to the ICOG clerical staff who work day and night, because we can see that the ICOG curriculum, so to speak, is so intense now. Every day there is something. So
we are having masterclass.
Shobha, you have forgotten to praise one speaker, and that was Dr. Shobha Guddi, who gave a brilliant talk too.
Thank you.
That is our job to acknowledge.
Excellent talk, Dr. Shobha.
Thank you. Thank you,
And
Dr.
Shobha, I would
Jaiswal.
like to announce that tomorrow we are having a very interesting ICOG masterclass on infections in pregnancy,
Infections.
not always scary. And it is free
Correct.
for all. So I urge everyone to please log in again at 4 o'clock.
Yeah. Yes.
Done.
So 4 o'clock is ICOG time.
Yes, ICOG time.
Chai
Learning
chai
time.
pe charcha in ICOG.
चाय पे चर्चा.
वो
Thank
भी
you very
चालू
much.
होने वाला है ये महीने में हम वो भी रोल आउट कर रहे हैं.
That's great. So now we can stop recording.
Yes,
Yeah.
we can stop the recording.
Okay, ma'am.
Okay. Bye.
Thank you.
Thank you.
Thank you very
Thank you,
much.
ma'am.